Hello and welcome back. This is Prof. Dr. Acharya from IMS and SOM Hospital, Department of Biochemistry. We continue with our catabolism of purine nucleotides. The background is that of Colosseum. Everything that has an existence today is perishable on this earth. So be humble. Sometimes which reigned the heart of the Romans now is in absolute degradation, or you can say in the phase of catabolism. So likewise, all the metabolic products that we are studying, they have some anabolism, they are created and they also get degraded. So that is the beauty of nature, that is the rule of nature. Now really before entering into purine nucleotide catabolism, let me talk about one incident that I came across. One of my acquaintances, a lady around 57 or 58 years age, she complained of severe pain in her ankle spreading up to dorsum of foot, right foot. And she was suffering like anything, and she went to 2-3 doctors. Finally, she was talking to me, and immediately I said, "Is it gout? Did they diagnose as gout?" She said yes. So actually, even the first 2 doctors, they got confused with the features, and they treated her in the line of rheumatism. Some told rheumatoid arthritis, and finally they went for few biochemical parameter checks, some tests, and pinned on the diagnosis of gout. So this gout is a disorder of purine catabolism. So you will be dealing with such patients who come to you, to your OPD or wherever you are working, and you have to think, keep your mind open and think about all possibilities. That is called differential diagnosis. So for this very reason, you must understand the basis of different diseases for which we are reading so much. Now coming to catabolism of purine nucleotides, you know adenine and guanine. The convergence product is xanthin, from which it will diverge, and finally in animals it will produce uric acid. Now this xanthin oxidase, it catabolizes the last 2 reactions, and this purine ribonucleotide degradation pathway is same for purine deoxyribonucleotide as well. So it is the same pathway, but we will learn in the line of purine ribonucleotide. So this is the overview of purine degradation. So here you can see from one side it is AMP, and in the presence of nucleotidase, hydrolysis of AMP occurs and adenosine is obtained, from which in the presence of enzyme adenosine deaminase we get inosine. Fine. And then again purine nucleoside phosphorylase, that means phosphorylase, nucleoside phosphorylase, it will remove the ribose 1-phosphate. Now where does that go? That will again be reutilized somewhere, or it will take another course of action, and what we get is hypoxanthine. Now xanthin oxidase acts upon this step and we get xanthin. This is the confluence molecule, where a common molecule that is really working from both sides. Likewise GMP, it is also acted upon by nucleosidase, similar manner to convert to its nucleoside, that is the guanosine, and then purine nucleoside phosphorylase, that is PNP, will give rise to guanine. Fine. And guanine deaminase will produce xanthin. So finally we come to this molecule xanthin, where again xanthin oxidase will act upon and we get uric acid. So this is the final product of both AMP as well as GMP. So is the pathway for the deoxyribonucleotides. Okay. We'll come to this pathway again when we discuss about its regulation and the different clinical conditions associated with it. But before that, let's know what is uric acid. So it is an excretory product, but yes, it is not only an excretory product, but it also has an antioxidant property and deals with 1/3 of the antioxidant action of blood or the body. Keeping aside that, let's see what is uric acid and how it takes its course of action. Once it is formed, part of it will be excreted into urine as insoluble crystal. Since we lack uricase enzyme, we excrete it as uric acid. So if we measure the blood level, this uric acid level that I am talking about is about the blood level. In males it is 3.4 to 7 milligram per deciliter, whereas in female it is 2.4 to 6 milligram per deciliter. But truly saying, these levels are little less for Indian population, because I have worked upon this. This was my dissertation during MD, and I have found the normal level in controls is around 2 to 3. If we actually it should come under hypouricemia level, but actually it is the normal level in our setup. Maybe because we take less of non-veg, we have a balanced diet more or less in all regions of India. So probably for that reason we have less of uric acid, but however we don't have a reference range for Indian population. Now in birds, terrestrial reptiles and some insects, they release this uric acid crystals in a paste form. You might have even got this experience when a bird poops over your head. So mammals other than higher primates, they have further modification, that is uric acid is converted to allantoin, then to allantoic acid, then to urea and finally ammonia. So this is the fate of uric acid in our body. Again, coming to a typical case of gout. The incident I initially described is a real life situation, but this is a typical case, a standard case of gout presentation. What happens? A 45-year-old man awoke from sleep with a painful and swollen right great toe. On the previous night, he had eaten a meal of fried liver and onions, after which he met with his poker group and drank a number of beer. He saw his doctor that morning and gouty arthritis was diagnosed. Based on what? Because the clinical features were having a telltale signs and symptoms. So it was very evident that it is going in favor of gout. He had pain in the right great toe and in the middle of the night after taking a heavy meal of fried liver and onions, both giving rise to excessive of uric acid, and then he has taken also alcohol. So these are all points in favor of gout, and the arthritis has manifested, so it is gouty arthritis. So his serum uric acid level was elevated and was found to be 8 milligram per deciliter, and of course the age is also important, 45-year-old man. So in the middle age group, late middle age group, it is seen. The man recalled that his father and his grandfather also had the similar problem. They were also alcoholic and they also had similar type of complaints. So this is a very typical case of gout. Then the doctor recommended some NSAIDs. NSAIDs like the painkillers that we commonly tell, like aspirin, and increase asked to increase his fluid intake, but not with alcohol. People can justify anything, right? And he asked to have some rest and elevate his food. He also prescribed allopurinol. This is the drug of choice in case of gout. Then a few days later, the condition was resolved. Allopurinol was stopped. Repeat uric acid examination, we got 7.1 milligram per deciliter. Then the doctor gave him some advice regarding lifestyle changes. This is the main thing that has to be inculcated to have a good health from all aspects. So this lifestyle modification can save you from many diseases. Maybe you are young at this age and you don't give a damn to all this, but if you continue with all the bad habits, in your mid 30s or late 30s, you will start manifesting all the metabolic diseases. So you can call this gout also as a metabolic disease. Now the earlier case that I described, that is also like little bit typical. The lady was in 50s, 57, 58 years, so perimenopausal age, just after menopause, and she is having hormonal imbalances and estrogen deficiency is there, and she had a joint pain, not in right grade 2 but on the right ankle. So whatever it is, it was a monoarticular joint involvement. Mono means single, so single joint involvement. So this also goes in favor of that, and she had redness, so quite a area surrounding that was quite red, and that also goes in favor of acute inflammation. And seeing her age, menopausal state, and her the typical pattern of monoarticular involvement, we can give a diagnosis in favor of gout, which the earlier two doctors didn't suspect. So there was no alcohol intake or heavy non-veg meal intake, but yet it was gout. And sadly, in India, though we don't have a proper incidence or prevalence study on gout, the incidence is increasing day by day, but we don't have a particular statistical figure regarding that. Now, why gout happens? Either it is due to impaired excretion or overproduction of uric acid. And these uric acid crystals, monosodium urate, they go and precipitate into joints, causing gouty arthritis, or in the kidney or ureter they may deposit, forming urate stones. So that is also another cause of these stones in there are different types of stones. So these urate stones, they may arise out of gout. So this xanthine oxidase that is catalyzing the last two steps is actually producing the uric acid. So if we want to inhibit production of uric acid, what we want to do? We want to check the activity of xanthine oxidase. So we give xanthine oxidase inhibitors. So that is the drug of choice. So allopurinol treatment leads to hypoxanthine analog is formed that binds to xanthine oxidase to produce that decrease uric acid production. So if you remember about enzyme inhibition, allopurinol comes under two categories of enzyme inhibition. One is competitive inhibition, the second one is also suicide inhibition. I hope you remember about all types of inhibition. A very interesting fact about this hyperuricemia or uric acid poisoning, you can say, this lead poisoning can lead to uric acid elevation by impairing its excretion. So it is said that one theory is put forth that in the fall of Roman Empire was due to probably lead poisoning. So lead poisoning led to hyperuricemia and different morbidities, and that was due to either drinking from pewter goblets made up of lead. And in the figure that is shown here, some lead pipes are found underground. So that was supplying the nobles' houses. So probably that was one of the causes of fall of Roman Empire. So this is a typical tophi deposition. The name is tophus, multiple in the plural it is tophi. So these rounded depositions, they are known as, the bodies are known as tophi. The right one, grade 2 is affected here. Here also in the joints, in the interphalangeal joints, they are seen. So not all gouts, not all cases of hyperuricemia will land in gout. Gout is some other manifestation along with hyperuricemia. So a hyperuricemia can be of due to different causes, like either it can be due to increased uric acid production or decreased uric acid excretion, as I told you earlier. So increased uric acid formation, it can be primary. So some genetic causes like enzyme defects in the PRPP synthase, the first step, and PRPP aminotransferase, Hg PRTase. So all these lead to increased uric acid formation. Then secondary, due to increased dietary intake of these non-veg meals, excessive uric acid supply through diet, or nucleic acid turnover. So in cancer and psoriasis there is lot of cell lysis, so more of the nucleotides being released, or there is a heavy ATP breakdown or deficiency of glucose 6-phosphatase, that is von Georg's disease. In these cases increased uric acid formation is there. There may be decreased uric acid formation, excretion. So it can be primary or secondary. Primary is idiopathic, no cause is known, but why it is excess, no one can tell. There is no clinical symptoms, and just it is, we should masterly watch it. If any symptoms arises, then we can take some action. Renal is secondary causes is renal insufficiency or due to different acidosis. So be it metabolic acidosis, lactic acidosis, or ketoacidosis, or starvation. Starvation also leads to ketoacidosis. Diabetes, uncontrolled diabetes mellitus may lead to again metabolic acidosis, or increased tubular reabsorption. So all these are secondary causes of decreased uric acid excretion. Then another clinical disease is there, Lesch-Nyhan syndrome. There is a defect in the production or activity of HGPRT. If you remember in the salvage pathway, so salvage pathway is reduced, or it is not producing, that is increasing the level of hypoxanthine and guanine. So that leads to more of degradation to uric acid. That is one cause. Also in this PRPP accumulates. So PRPP accumulates means it produces production of purine nucleotides and then increase their degradation. So this also has gout-like symptoms, but how to distinguish between this? There are some neurological symptoms like spasticity, aggressiveness, self-mutilation. Now what is this self-mutilation? The patient will bite its acral parts like fingers, the acral parts, wherever it feels like, it will bite and harm itself. So this was the first neuropsychiatric abnormality that was attributed to a single enzyme. That is quite interesting. So this is a case of Lesch-Nyhan syndrome. Not many cases are reported from India, but definitely it is there. In Western world it is more evident. So there is a beautiful mnemonic for this: self-confident men get heavy success. self-mutilation, chorioathetosis, mental retardation, gout, and hyperuricemia spasticity. So, taking the initials of this mnemonic, you can remember this: self-mutilation, chorioathetosis is there, mental retardation, gout, hyperuricemia, spasticity. These patients fail to thrive beyond a certain age. So, that is about Less-Nahan syndrome. Then if there is hyperuricemia, that must be hypouricemia. When do we call it? If uric acid level falls below 2 milligram per deciliter. This is either due to decreased production or increased excretion. No symptoms or pathology is seen, so no treatment is required. It is usually seen in case of intake of uricosuric drugs. Excessive uric acid is eliminated, so uric acid has fallen. X-ray contrast materials also may lead. Then TPN, hyperalimentation. TPN is total parenteral nutrition, that is bypassing the GI tract when we give nutrition through IV line. If it is complicated, then also we get hypouricemia. Neoplastic diseases also we get hepatic cirrhosis, diabetes mellitus, CIAT, Fanconi syndrome, and in Less-Nahan syndrome. So, hyperuricemia is seen in case of diabetes mellitus, but at certain stage it is also leading to hypouricemia. So, it all depends. So, you have to have a clear concept of all these basics, so that when you treat your patients, you should remember all this and treat accordingly. Now, another case, that is severe combined immunodeficiency syndrome, where adenosine deaminase deficiency is seen, and there is a mutation in the gene RAG1 or 2. Here the B and T cells are dysfunctional, so there is less immunity. So, that is why it is combined immunodeficiency. Both B and T cell immunity is less, and here deoxyadenosine and adenosine are abundant. They inhibit further production of precursors of DNA synthesis, especially DCTP. Now, here also hypouricemia is seen because defective breakdown of purines is seen. This is also nicknamed as bubble baby syndrome. This was the first disease to be cured by gene therapy because it is a single gene disease. So, this is the overview of purine catabolism as well as the enzyme deficient leading to which disease, like ADA deficiency will lead to SCID, that is bubble baby syndrome. Then this xanthine oxidase is inhibited by allopurinol. All these are seen in this. So, knowledge has no copyright, it is free. Only thing you have to go through it, realize, practice, and put it into your clinical practice. Thank you all.